play a critical role in creating the conditions to achieve health for all. So at the centre of understanding civil society advocacy and social movements which have led to social change is understanding how these movements and actors engage in and challenge the structures of power that make up and inform governance systems. So Campbell and Cornish, in their 2021 article, refer to public health activism as any attempt to redistribute power in ways that create more health-enabling social environments. So these are environments in which previously disadvantaged social groups are empowered to exercise greater control over their health and well-being. And they write that while some public health researchers and professionals view health-related agency as an individual matter, where individuals are seen to carry the responsibility for behaving in health-enhancing ways, others point to more collective sources of agency, pointing to the significant impacts of peers, communities, and/or social structures in enabling and supporting health-related behaviours. They argue collective agency is seen to lie in any activities by members of vulnerable groups and their allies that increase their opportunities for health and well-being. And we concur with the authors that civil society organisations and their activism and advocacy is one pathway to achieve this collective agency and improve health promoting environments. So in the Restoring the Fair Go project, we're aware that sitting alongside our focus on collecting evidence on health equity and policies to address health inequities, we need to attend to the relations of power which cause and maintain social and health inequities, and better understand how civil society and communities have been challenging unequal power relations and creating political will to address health inequities in Australia, and how might they and we do more. This feels particularly poignant as with much social upheaval over the past few years, there's been global trends towards both growing social and health inequities. And at the same time, groups like Civicus have been documenting how governments are increasingly cracking down on or restricting civil society activism and advocacy. So in this project, the first stage of understanding the civil society landscape in Australia has been to map through desktop analysis civil society organisations in Australia who are advocating for health equity. And I'll go through some of our findings so far. So our methodology has been guided by Dori Patay and others' 2022 article, in which they conducted an exploratory descriptive analysis of NGOs online to identify the NGOs and the roles that they play in the governance of ultra-processed food and alcohol industries in Australia. We adapted the methods to the topic of health equity and civil society in Australia, taking a bit of a narrower focus on civil society advocacy activities focused on the agenda setting phase of governance. So Downey defines advocacy, which is part of agenda setting, as activities aiming to define a problem and placing it on the policy agenda. This involves collecting and disseminating information and advocacy to government and industry. So we're really interested in finding out who are the organisations and groups advocating for action on health inequities and having influence in this governance space. So included in our search criteria were civil society organisations who have been active on these topics from 2017 to 2022. We also looked at a broad range of type of civil society organisations, so including public interest non-statutory organisations, meaning not accountable to government, as well as semi-public administrative bodies outside of government but receiving support, coalitions, industry-funded organisations, professional associations and private philanthropies, and also some smaller community organisations. But recognise that as this is a desktop analysis, many of the kind of smaller civil society and community groups, which are doing great work, aren't easily kind of analysed online, so aren't included in this data collection. We also note that the term health equity is not common outside of the health and public health space. And so included in the scope were activities related to the social determinants of health equity. For example, this might look like a media release by an organisation linking the housing affordability crisis to social inequality and the impact on renters' health. So we were keeping it quite broad. The types of activities we were searching for included participating in relevant government consultations through submission or testimony, publish relevant position papers, reports, blogs, media releases, working with policymakers on relevant policy issues, webinars, podcasts, and other presentations, as well as evidence of other advocacy activities such as speaking at public events, email campaigns, and activities aimed at community awareness raising on the topic. In the data collection, we included both targeted and snowballing methods. So we began with an online search of government and civil society websites to identify organisations that met the study inclusion criteria. Initially, we collated a list of identifying peak non-governmental organisations working in the health and equity field in Australia and looked at their member lists on the websites. Additionally, we went through every consultation list on the PHAA website and searched in Google, and those with publicly available records were identified, enabling the identification of organisations that engaged in consultations on health equity issues. So then once we had the organisations, we individually searched their websites manually for organisational aims, missions, objectives, affiliations. We located web pages with submissions, publications, media releases, and scanned documents on that page and conducted word searches such as health equity, health equality, social determinants of health. So some websites like the ones on the screen were really easy to identify their advocacy work around health inequities, while others we had to dig a little deeper. So then activities were recorded if the organisation reported participating in relevant advocacy activity. Then a database of these organisations and their activities were compiled in a Microsoft Excel document, and I think I put that on the last slide, so it was just that one, a little snippet there. From the desktop searching, we collected information on name and type of organisation, whether their activities were directly or indirectly related to health equity, the issues and topics that they were advocating for, the types of advocacy activities, and we also noted existing networks and collaborations advocating for health equity, as well as non-civil society organisations such as university networks. So again, I've just given a bit of a snapshot of some of our results there. We're still finalising the results and yet to publish. So we found that 107 organisations were engaged in activities advocating for change to address health inequities during the period of 2017 to 2022. This included either being involved directly or indirectly in health equity. So by indirectly, I mean social determinants of health inequities such as housing, climate change, which the organisations then linked to health and inequities. We found that most organisations actually covered both, with only 33 only engaged indirectly in health equity advocacy, meaning basically that they didn't use the terminology of health inequities or inequalities. We noted the issues that they advocated on and divided them into 5 primary areas. So as seen in the table, many organisations covered multiple areas. These issue categories are not mutually exclusive, but reflect the primary focus of the civil society organisations. So for an example, an organisation might be focused on cancer, but also on broader health policy issues to do with disease prevention. So we noted those. The primary issue areas we noted were risk factor specific, so obesity, substance abuse, exercise, those sorts of things, and found that 40 organisations primarily focused on those. We also noted disease specific, so stroke, diabetes, for example, and that 44 of the organisation focused on those issues. We focused on broader health focus, so policy and health system, and noted that 96 of the civil society organisations' advocacy activities included this broader health focus. We then looked at the social determinants of health equity. So again, a broad range of things like housing, poverty, income, education and food, and noted that 90 of the organisations included a focus on the social determinants of health equity. And 55 included as their primary focus their activities related to professional associations and health workforces. So considering our inclusion criteria and that we were looking for advocacy activities, it's not surprising that the overwhelming majority of organisations had a primary focus on the social determinants of health equity and a broader health system and policy focus. We also noted the types of activities undertaken. So most common were, position papers, policy statements, government submissions, media releases, and less common were like research reports, webinars, and engaging more broadly with community. Another interesting question which surfaced when looking at the organisations is around how many of them were primarily health focused. Because we broadened out the inclusion criteria to organisations involved in social determinants of health equity activities, we found a range of organisations. So 26 out of the 107 civil society organisations were not health focused. They included, for example, the Australian Council of Social Service and the COS networks, Shelter SA, Anti-Poverty Network, Oxfam Australia, and Australian Council of Trade Unions. And I think moving forward, that's something that needs further investigating is what this means when potentially looking for collaboration or support around health equity issues for health or other organisations. As stated, health equity as a term was not common outside of health orgs on their websites and in their documents, but the terminology around social determinants of health and around social inequalities and inequities was, meaning there's quite broad literacy on these issues and scope for working on related health equity issues, even if the language and topics differ. So it was not a key objective of the mapping, but it has been interesting to also find pre-existing networks, so whether policy focused or research focused, involved in health equity advocacy. And I've just listed some of them on the page there, and there's probably others. And part of the translational objectives of this project is to invite, as Fran mentioned, is to invite civil society organisations identified from this desktop mapping to join an Australia-wide health equity learning lab network. So identifying who is already collaborating and bringing together different organisations and sectors is something we're definitely interested in learning from. So we aim to examine with representatives from civil society organisations how advocacy can affect government's political will to act on health equity issues. And we want to do this through creating a health equity learning lab over the period of this study. So we're looking at from the remainder of this year to 2026. So just a little bit on what we mean by a learning lab and how we're proposing that it works. So based on social network theory, a learning lab is a type of social network. What differentiates it from other networks is that its purpose is to build capacity and agency amongst members through processes of collaborative action. So Scott and Hoffmeyer state that social structures such as networks influence the action of individuals and that collectively networks have the capacity to challenge fundamental society issues. So the Learning Lab is intended to develop as a collaborative Australia-wide network of organisations and people advocating for health equity. The lab will evolve dynamically over this period and a variety of means will be trialled to engage and build collaboration. This network will be guided by participatory action research principles and is intended to build on existing capacity amongst members and the organisations they represent. So this means building capacity in two areas. So one, around advocacy and translation skills, and two, knowledge of health inequities, its causes and possible solutions. So we also envision this to be a learning space to share experiences, both positive and negative. Hello meetings will therefore be a participatory space, but we also are keeping it quite broad at this stage as really the aims, activities and outcomes will be decided by its members. And if you're joining us today and are from any of these organisations you may have seen on the screen, you'll probably expect an email from me very soon, as we've just received ethics to proceed with this part of the project. But I'm also happy to be contacted if you're interested, and welcome any comments in the comment section of this webinar if you'd like, to what you'd like to get out of the Learning Lab and what would benefit your work and your advocacy. So lastly, I'll just mention that the next steps of the mapping of the civil societies is to finalise the analysis and hopefully publish those. So I'll just end there, and thank you and welcome any discussion.
That's great, Connie. Thank you very much. I think you gave a fantastic overview of why we've developed a Health Equity Learning Lab and how we hope to be linking up researchers and people in civil society. I think participants, you can ask questions in the Q&A, and if you want to ask the question yourself, we can enable you to speak. So please just note in there, I'd like to ask a question. I'd just say, Connie, what do you think are the kind of main barriers to, you mentioned the importance of advocacy and translation, because there's a lot of information. One of the reasons we're doing this Hello is because we know there's so much information about health equities that it's almost like we don't need more. We can understand a bit more, but we actually need translation so that policymakers will take action on it. How do you think that, have you got any ideas how that might be done better?
I think there's a lot of groups working on health equity issues, but it's not under that banner. So I think it'd be interesting to identify where those gaps are and looking for more ways to collaborate, I think. There isn't, as we know, a lot of people joining would know, there isn't a lot of money for networks and collaboration and intersectoral collaboration. So I think that's a really big barrier. I know a lot of groups would kind of think health is not their area, but if there was, a way of networking or collaborating, maybe those opportunities could be extended on.
I mean, I think quite rightly, the inequities between Aboriginal Torres Strait Islander people and other Australians are well highlighted. And in fact, our next webinar will be looking at some of the reasons why there has been even some progress. But with socio-economic inequities, there's not perhaps, I think there is a loud advocacy voice from bodies like the COSs, like ACOS and SACOS in South Australia and so on. But otherwise, it seems that often socio-economic inequities, the gradient isn't shown as much. Do you think that's the case from looking at all these different websites?
Yeah, although I do really feel that there is a movement, I think, with the cost of living issues becoming such a bigger area and in the media, that I think people are recognising socioeconomic issues and the causes as well with housing and income. But yeah, it's still a lot of work. And I think, again, linking it to the impacts on health, I think.
Yeah, and I think certainly in the housing area, there's quite a lot of work now that's been done on, not surprisingly, homelessness is bad for your health. I mean, we know that, but unpacking that a bit more, but also looking at housing stress when rents are going up, mortgages are going up. And I think we can expect that to all have a big impact, particularly, I think, first, the kind of canary in the room will be mental health impacts over the next year or so. I guess one of the other things that I think is something that will come up in the Hello discussions is how do we position ourselves as academics? And people may know that I've been very active in the People's Health Movement, and Connie has too. Do you have any reflections on that, Connie, on your positioning? I know that you're active in a number of social movements, and often, we try and draw these distinctions between these different parts of our lives, but how do you see them actually fitting together and how we might want them to fit together?
Yeah, it's a good point. I think often because of the nature of research and funding, we kind of get funding for discrete projects and then we move on, and that doesn't fit with kind of the slow movement of social movements and advocacy. And I guess it's for us, it's about also finding how our research can be more translational and more useful for people doing activism and in social movements and civil society more broadly.
Yeah, and of course, I mean, I think the other thing is Connie and I worked on a study where we interviewed a range of people's health movement activists who had been engaged for many years, and they all said it can take a toll on your health when you're trying to do your mainstream job and the activism. You know, it's not always the easiest thing, so that's really good. Before we move on, I just noticed that Richard Porter's put a question in thanking you, and he's asking you for guidance around what are the most effective ways to carry out advocacy, some examples of what work, and that might be helpful, especially for young public health practitioners who don't have a lot of experience with advocacy work. And he then adds, and self-care is very important. So any hints for young public health practitioners who want to be activists as well?
That's a huge question. I think firstly, joining, no, that's all right.
He's apologised.
Yeah, it is a good question. I think probably looking to the networks who are already doing work like PHAA and starting to get some, it can be really daunting, especially, and people might not feel comfortable going to the streets and doing that more kind of that type of activism. So I think just joining some of those networks in your, maybe around your professional bodies is a good first step. But I think also, it's really overwhelming and sometimes you feel like a little action doesn't work. But I think as we've seen, even disappointing raise the rate amount. But I think in that recent federal budget, if there wasn't the big social campaign, so emailing and MPs and all that, I don't think we would have even got that or got it in the headlines. So just those little steps, I think.
Yeah, that's great. So often it is about little steps, you're not going to suddenly get the change. I think that's an important message. So thanks.
Reaching out to others as well, so you don't feel like you're doing it alone, and lots of debriefing.
Oh, we've got a couple more questions. We've got a few more minutes. Someone said they'd like to raise inequities of service for people living with obesity and lack services provided in low socioeconomic areas. I think in Adelaide we'd be thinking of areas such as Playford and Christie's Downs and so on. So any comments on that one? I think just to recognise it is a really important issue, I think. So thanks, Andrew, for raising that. And then I think the last one for you, Connie, is James from the Australian Unemployed Workers Union, and that's a group that do fantastic advocacy on the rights of unemployed people. They say that they've really looked at how health issues affect people's capacity to engage with employment, but less so on how those employment services affect health. So is there much work being done on that aspect? Well, I think I could say that we've certainly, Julia Anaf in our group has been looking at that. She looked at that in her PhD in terms of the Mitsubishi workers who were kind of made redundant in Australia and how the employment services didn't really suit their needs. And we've certainly identified that since the privatisation of those services, they perhaps haven't fulfilled the needs as much as they might. So we do think, James, that's a really important issue, and we hope to be looking at it over the next couple of years. And we'd love to talk to you, of course, about that and how we can get some lived experience. So that's really good. Okay, that's great. Well, one of the other, thanks, Connie, that was brilliant, a great presentation, and it's really introduced us to, how we're kind of having a research-based, hopefully, learning lab, and we will be talking to the people who are willing to talk to us in the various organisations and asking, amongst other things, how would they like to see this learning lab meet their needs. And the other big question I always think with health inequities is that sometimes when you're living in a society, you don't see them. And very often it's by comparing your society with another society that you can see how well we're doing. And we've been working on this idea for a number of years, and Toby Freeman's been leading much of that work. We've, as part of that, we have established what we've called a punching above weight network, which is looking at how some countries do better than others. But Toby's really going to reflect on how can we compare countries and how well they're doing on health inequities. So over to you, Toby.
Thank you very much, Fran. I'd also like to acknowledge that I'm presenting on the lands of the Ghana people, where I work and live, and pay my respects to elders past and present. So as Fran said, one of the elements of the Restoring the Fair Go program I'm working on is how can we compare health inequities between countries? And I think it's useful from a research perspective to be able to do that. But I also would hope that it's useful from an advocacy and civil society perspective, that these international comparisons can obviously be a really good arguing point for what is possible and what other countries have implemented that we'd like to see implemented here. So firstly, I want to introduce a graph called the Preston curve and explain what it tells us about comparing health between countries. And then in the second half, I'll move on to comparing health inequities between countries. So firstly, this is what's called the Preston curve, named after Samuel Preston, who did the original graph back in the early 1970s. And this is one I've created for today from 2021 data available on the World Bank website. And I was first introduced to this graph by Fran when she brought out to Professor Michael Moran from the UK. Gosh, probably 2 decades ago now. And he put this graph up. And what it shows on the y-axis is the life expectancy at birth for all the different countries in the world, or very, very close to all the countries where we have the data. And on the y-axis is the gross domestic product per capita for each of those countries. And it kind of graphs the relationship between those two factors. But the first point that I remember Fran and said, Professor Michael Marmot, using the graph for is just to firstly show that variability in life expectancy at birth. So across countries, it ranges from the low 50s up to about 86. So that's over 30 years variation in life expectancy between countries. As Anasta pointed out, there's no biological basis for that. That is entirely down to people's living and working circumstances and the power and economic and healthcare differences between countries. So it's entirely avoidable that we have this astronomical life expectancy difference between countries, and it should be a really urgent public health matter that these huge global inequities in health exist. And then the second thing the graph shows you is that relationship that life expectancy has with gross domestic product per capita. So you can see that life expectancy increases as gross domestic product increases. So particularly the first $20,000 per capita GDP really can dramatically increase the life expectancy of your country, again from the low 50s up to about the mid 70s. And after that, as gross domestic product increases, there's diminishing returns, but you can still see it increases life expectancy as the country gets richer. But as with any regression, you can draw a trend line through that to show the rough trend of what the data is telling you. And you can see that trend line on the graph there. But of course, as with any trend line, some of the dots on the countries sit above the trend line and some sit below it. So it's an interesting question to think through those countries that sit above that trend line. They have a longer life expectancy. They're healthier than what you might expect from this model, given the country's gross domestic product. So is there things that those countries are doing well in the way they're turning their wealth into the health outcomes for their population that, you know, we as researchers, we as civil society advocates can learn from and argue for? And conversely, below the line, are there things that those countries are not doing so well that means their wealth is not getting translated into better health for their population in the same way that some other countries are? And are there things we can learn from those countries to avoid doing to maximise the health of the population? So it struck us that, you know, this kind of issue was ripe for learning from international comparisons around what we could do better in Australia and what we can advocate for generally globally. And so what the Preston curve then allows you to do is to calculate the life, we get the life expectancy of a country, again, from that World Bank database is really useful. We can calculate what life expectancy would be predicted by that regression in gross domestic product. And then we can calculate the difference, which is essentially the gap between the dot on the graph and the general trend line. And what that residual shows us is whether a country is punching above or below weight. So if you look at row 12 there on Australia, we have a life expectancy of 83.3, whereas our gross domestic product would estimate that we would have a life expectancy of about 79.3 years, which means we're actually punching 4 years above our weight, which is a fantastic outcome. So in Australia, we seem to be pretty good at turning the nation's wealth into good health of the population. You can see that Bangladesh also does really well, punching 4.9 years above weight, but there are countries on the list that aren't doing so well. So Angola or the United Arab Emirates or Azerbaijan. So there are things there that are happening that mean that they've got a lower life expectancy than what you predict from their gross domestic product. And what you can do once you've done those calculations is come up with these tables of which countries are punching most above their weight and which countries are punching most below their weights. And I've been doing these kinds of tables for several years now, for about 5 years. And what I've noticed is that the countries that populate the very top and the very bottom of the table haven't changed very much, with the exception of when I did it for today with the 2021 data for the first time, there was some substantial movement around the punching above weight countries. And I think we can attribute that to COVID, which would have dramatically affected all countries' GDPs in slightly different ways, and also obviously dramatically affected the health of the population. But I think it's interesting to note that there's lots of islands that are now at the very top of the punching above weight table, and perhaps that's due to the kind of natural advantages of islands protecting themselves during the COVID pandemic, which we certainly saw in Australia and New Zealand. The challenges of land borders and movement through the EU, for example, exacerbating the toll of COVID. But interestingly, the punching below weight countries really haven't changed very much at all over the years that I've been doing this. And so what these tables tell me, if we start with punching above weight countries, is that the West, or whatever terminology you want to use, are not the ones that are leading these league tables, if you want to call them that. The highest country that I'd consider kind of Western would be Spain, which is doing a fantastic job on punching 5.4 years above weight, and is ranked number 15. If you're interested in kind of Anglophone countries, and the highest are Australia on 4 years above weight, and New Zealand on 3.8 years above weight. So whereas the Western and the Anglophone countries might dominate a lot of this research, they're really not perhaps the countries that we could be learning the most from. And so I think that's really interesting. And then I think the clear learning outcome from the punching below the weight countries is they're dominated by African countries. And to me, that speaks to those global forces of of power and colonisation and unfair and unequal finance arrangements. You know, the history of things like the structural adjustment programs that really supported the power inequities between Africa and the developed world, and really undermines their capacity for health and sovereignty, I guess. Extractive industries are likely, we suspect, to play a big role in whether a country punches above or below weight. And, you know, the role the global institutions have played again in perpetuating these kind of ongoing colonisation and power inequities. So when we started this work, you know, in about 2018, and so, you know, 3 years later when COVID hit, we thought, well, surely these countries that punch above weight are going to handle the COVID pandemic better than the countries that punch below weight. And we were surprised to find that actually that wasn't the case. So this is a graph that we did in the early days of COVID. So this is September 2020. So capturing, you know, really those first experiences of COVID, and it's all kind of got muddier as time goes on after that. But you can see that some of the punching above weight countries like Peru and Belgium and Brazil and the UK were the hardest hit by COVID, and had, you know, lots of deaths per million people compared to other countries. So I think one of the takeaways from that is that a country's ability to punch above or below weight to translate their wealth into health is going to keep changing, and that's something we're going to have to keep reflecting on and keep learning as the world changes around how that affects whether countries punch above or below weight. So this is a photo from when we first set up the network, and, you know, particularly as a tribute to Fran and David Sanders, just to her right there, who really helped organise and bring a wide range of researchers, of policymakers and civil society actors together to start thinking about this problem and how we might go around interrogating it. And learning from the different countries. And out of that first meeting, this is the theoretical approach that we came up with about what factors we think might affect whether a country punches above or below weight, and also the equity of the distribution of health within countries. So on the left, you have those big global economic and political and ecological contexts that I kind of alluded to with the African countries. Then at the level of the country, you've got the geography, the population demographics, the national, political and institutional context and history that all shapes the kind of current day economic, social, environmental, health policies and the social conditions in that country. And they're going to shape the immediate social determinants of health that affects the kind of everyday lives of the population. So things like healthcare, opportunity for democratic participation, education, food supply, employment, income, housing, environment, gender, and so on. And then the third column, we can illustrate how those different social determinants will have an impact on health. And all of that will then contribute to the ultimate outcome of whether a country has a better or worse health compared to their GDP, and the equity in the distribution of that health within the population. And then down the bottom, we just note that all of these things are not inevitable and they're not static, that we can influence at different levels how these factors and levers are pulled towards health or away from health through civil society action, through social mobilisation for health, and through inclusive participation in democratic structures. So again, I think that's one of the clear links with the work that Connie was presenting, where all of this is kind of innate of what lessons can we learn that can support advocacy and civil society action to improve health inequities. So to bring it back to Australia then, which, as I've noted, has a great outcome in terms of it punches above its weight, it has a high life expectancy of 83.3 years, But we know that not everybody is benefiting from this result. We know that there's a huge health inequity gap between Aboriginal and Torres Strait Islander peoples and non-Indigenous Australians as a result of ongoing colonisation and inequities in social determinants of health and the continual denial of sovereignty and ongoing racism and discrimination. And we also know that there's a very large socioeconomic gradient in health, which means that not everyone is equally benefiting. And this is just one graph to demonstrate that socioeconomic gradient in health. And this is from the PAW Social Health Atlas, which you can find on the web, which has a great range of graphs of different health indicators and outcomes. And this one is premature death, people dying before their 75th birthday. And the lighter colour is data from 1987 to 1991. And then the darker colour is 2016 to 2020, so the more recent data. And again, the real good news is that premature mortality has gone down across the board. That, less people are dying before their 75th birthday than they were in 87 to 91, which is great. But as you can see, not everybody has equally benefited from that. So the richest areas of Australia, the areas with the least disadvantage, is that far left there, quintile 1. And you can see that they've enjoyed a reduction of 47% in premature mortality in those areas of Australia. Whereas the poorest areas of Australia on the right in quintile 5, the areas with the most disadvantage, they've only experienced a 31% decrease in premature mortality. And what that means is that there's now greater inequity. People in the poorest areas of Australia are now over twice as likely to die before the 75th birthday as people in the richest areas of Australia. So that inequity, that social gradient is getting worse because not everyone is benefiting to the same extent. So that begs the question for us is, well, how is Australia faring in that regard? Are all kind of countries experiencing this growth in health inequities? And are we more unequal than other countries? And I perhaps naively thought that this would be a fairly straightforward question to kind of ask and answer. And I was very wrong. So in the literature, there's two basic approaches to trying to look at how unequal a country is around their health. The first is the univariate approach, which is similar to the Gini coefficient, which you might have seen for income inequities, which just indicates the extent of variation. So a high Gini coefficient means there's a high variation in people's incomes, which we would say, by definition, is income inequality and is unfair if that's a really wide variation. But in health, I don't think it's that straightforward. It captures all variation in health, not just health that's unfair or unjust variation. And it doesn't give any indication as to who or where is subject to those health inequities. So it's not very useful in answering the kind of questions that we want to ask. What I think is much more useful is what's called a bivariate approach, or just more than one variable approach. So we might be interested in looking at health inequities by gender, or health inequities by socioeconomic status, or health inequities by race or ethnicity or country of birth. And to continue kind of focusing in particular on socioeconomic inequities, if that's what we're interested in, there's a whole different range of indicators that researchers have used to try and answer that question. And all of these different indicators have different pros and cons, as you can see from this table, which I won't talk through the details of, but just to illustrate that, some researchers use education level to compare inequities. Some use occupational class, some use household income, some use wealth. And there's pros and cons to all of them, and none of them are perfect. But all of them kind of give us clues as to what might be going on with the way we structure in our societies and how that affects health inequities. But what really matters is what data can we get a hold of and what can that data tell us? And I'm just going to quickly cover some work we've done that, again, we're working on at the moment, is not yet published. But what we found in our searching is the best health inequity data we've got to compare countries on at the moment is the World Health Organization's Health Equity Monitor. And this is a database of 92 low and middle income countries, and it has a whole range of health indicators. The ones I'm most familiar with that I've worked with are infant and neonatal and under 5 mortality rates. And for these health indicators, they break them down by wealth quintile, which they explain is derived from a household wealth index that is country specific, which makes sense, that what constitutes wealth and what spectrum that wealth sits along is going to vary greatly between countries. And so they kind of determine it for each country based on owning selected assets or having access to certain services and so on. What we did was try and work out the extent of inequalities in this example for infant mortality in all of those 92 countries. And so we used the slope index of inequality, which again, the higher that index, the more inequity there is within that country. And again, we graph that against gross domestic product per capita because we were curious to see if there was that same Preston curve for inequalities. And there isn't. So what the graph is showing, I think, is that on the left, so in the poorer countries, the countries with the lower gross domestic product per capita, there is a wide variation in health inequities. Some of those countries have very low inequities, and some have very high inequities in infant mortality. And as the gross domestic product increases, as you go along towards the right of the graph, that variation gets really substantially constrained to the bottom half. So that overall, as gross domestic product goes on, you'd expect inequities in that country to be somewhat smaller. But it's not a very strong effect. You can see that there's a real broad smattering around that trend line. There are some advocates who argue that what we should be pushing for is just to raise the gross domestic product of all countries, countries experiencing inequities in gross domestic product, the developing countries that we want to improve their gross domestic product for. But this and other data suggests that that's not the whole story, that we also have to attend to how that gross domestic product has been turned not just into health outcomes, but turned into equitable or more inequitable health outcomes. And so what this study taught us was that there's a wide range of challenges we're going to have to think through if we want to be able to generate findings that will be useful for civil society advocacy and researcher advocacy. So that these include, how can we compare with high-income countries? We could only find 3 high-income countries with relevant data for infant mortality by socioeconomic quintile. And we couldn't find any data for high-income countries for under 5 mortality by socioeconomic quintile. We originally wanted to do it on life expectancy by socioeconomic quintile, but we could only find 12 countries across low, middle, and high-income countries that we could find that data for, which wasn't enough to kind of construct a graph for. Does it even make sense to compare socioeconomic inequities when that socioeconomic spectrum will differ so wildly across different countries of the earth? Are we comparing apples with apples when we're trying to look at inequities in some of the poorest countries compared to the high-income countries? And because of these challenges, what I found in the literature is most studies have stuck to just comparing European data. For example, Mackenbach, who's one of the leaders in this field, has solely kind of compared kind of European mortality registers and so on, which is great, and we're learning from that in terms of what might be good policies or not. But obviously, we'll learn a lot more if we can expand the literature beyond just Europe. Is there any way of comparing racial health inequities between countries? The only example that I found that really tried was Siddiqui and Nguyen, who tried to compare racial health inequities between Canada and the USA, and they ended up just having to default to white versus non-white and native-born versus foreign-born, which is obviously limited and won't apply to all country contexts. Gender inequities, Fran and Connie have researched in considerable detail, and there's lots of conundrums there around the fact that life expectancy is high for women, but women may experience worse morbidity and worse social determinants of health. So kind of untangling those pathways is really important. And if you're interested in health inequities by sexuality or gender diversity, then we know that all these big databases only have the binary of males and females, and that our comparable data on sexuality and gender diversity is really poor. So that's going to be a real challenge to try and compare how countries are doing in supporting these really important populations that are currently essentially invisible in the major data sets that are being used. So I think that's a critical challenge as well. So more challenges than answers, but I think it's a really kind of interesting area of study that if we can get right, I'm hoping will generate findings of real use to civil society advocacy.
Great. Thanks very much, Toby. That was great. I encourage people to put any questions into chat or the Q&A section and we can deal with those. I just wonder, Toby, I mean, what you've essentially said is that it's very, it's not easy to understand the reasons behind health inequities, and that very often we're kind of using a fairly crude measure. Are there other methodologies you're investigating that will enable a clearer example of how we can look at all those systems underpinning health inequities?
Well, I think, as a group, partly based on those quantitative experiences, but also partly, based on kind of the expertise of yourself and Jenny Popper and David Sanders and others, I think what as a group we've emphasised is going to be really key is the really in-depth case studies of countries that whenever you try and reduce these kind of really complex issues to basic quantified statistics, that you're missing out on an awful lot of context and pathways and local understanding. So I think what we're really keen to pursue is to do a suite of really, really in-depth case studies, looking at policies in selected countries, interviewing experts in that country, and really being able to put together a really strong, credible picture for the drivers of health inequities in those countries and what the health inequities look like in those countries, and using more qualitative approaches and maybe qualitative comparative analysis approaches to really understand and distill lessons from comparing a small range of countries in a qualitative manner rather than trying to go this big, broad quantitative manner. So I think we could learn an awful lot from that.
And I mean, it obviously calls, some people are using systems thinking. Have you given what's your thinking on using systems thinking?
I think it's exciting and terrifying. So I think, the discussions we've had with people in government, with civil society, I think one of the benefits of systems thinking is that we could really capture the complexity of what a range of different drivers are in different sectors. So capture the impact that income, wealth, housing, education, employment, working conditions, environment, how they might all come together to determine the health of a population, how they might interact, the feedback loops that might kind of occur between income and housing, that I think we can see in the kind of current cost of living crisis and the way we're talking about it now in Australia. There's a complex web of interrelated determinants that you can't just distill into a kind of a linear determination of health. So I think it's brilliant for highlighting how complex that system is and just how many different levers there are that we could pull. But the challenge is that they're often criticised as really massively complex spaghetti diagrams that you can't learn anything from. And I think, the core of what we're trying to do again is to try and influence policy and to try and support civil society movements towards greater health equity. So the trick with that will be presenting the complexity, but then still being able to work out what to advocate for given that complexity.
Yeah, no, I think that's very well put. It reminds me of that saying, there's a simple answer to everything and it's invariably wrong.
Yes, exactly. And I think we're seeing people articulate that kind of a thought around the kind of the inadequate response to raising the rate in housing and so on, kind of
Yeah.
contain the socioeconomic inequities we're seeing rise and rising norms.
Well, that's great, Toby. Thanks for introducing us to some of those complexities of inequities and some of the thinking that we're doing about how we can do some comparative analysis. That's fantastic. So that's the end of today. I just want to do a plug for the next learning lab, which will be on August the 14th, same time, lunchtime. Bring your lunch along and sit at your desk and watch it. We've got two great speakers, David Scrimmager, who's worked for a long time in Aboriginal health services, and he's written a book which he published last year called Remote as Ever, The Aboriginal Struggle for Autonomy in the Western Desert. And he's going to talk a lot about Aboriginal community-controlled health organisations and how they're helping to close the gap. And we'll also be joined by Michael Larkin, who's a senior lecturer here at Adelaide University and who has had a lot of experience in Aboriginal community-controlled health services. So please join us for that. Please let us know if you have ideas, particularly email Connie if you have ideas for how we can develop this learning lab, what you'd like to see with it. Where this year it's mostly about presentations, next year we want to be more interactive. So any ideas you've got, that would be brilliant. But otherwise, thanks to Connie and Toby for their wonderful talks, and we hope to see you all next time. Goodbye.